I think we're all here, so we'll go ahead and call the meeting to order. And if you'll rise with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, Dee, if you could call the roll.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart.
Present.
Director Epen.
Present.
Director Wallace.
Present.
Great. And Dee, if you could tell us who is in the boardroom with you.
We have Kimberly Hartz, Ed Fayen, Chris Henry, Larry Lavoisier, Paul Kozachenko, Nicholas Kozachenko, Shri Badu, and me, Dee Antonio.
Okay, you got a full house there. Great.
Yes, we do.
Yeah, we have a number of other guests that we can see. So welcome to the September 8th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. In accordance with Governor Newsom's reopening plan for California and Executive Order N-2920, we will continue to conduct our meetings remotely while we develop plans to return to in-person meetings and develop hybrid formats that maintain Brown Act compliance while also providing greater accessibility and transparency to the public. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's session. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. We'll now move to the communications segment of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Dee, are there any written communications?
No, there are not.
Very good. We'll now move to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none. Does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar items A? Bernie, I think you're muted.
I'm sorry, I thought I had it unmuted.
I know it's.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar item A.
Thank you. Do we have a second?
A second.
Great. We have a motion and a second. Dee, if we could have a roll call vote.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Great. The consent calendar is passed. And now we have presentations. Kimberly, if you could introduce our presentations.
Yes, it is my pleasure this evening to introduce Joanne Pineda. She has a special presentation for the Board of Directors. She is the Quality Improvement Manager and Quality and Outcomes Research and Analytics for the American Heart Association. So she is with us this evening to present Washington with an important award. I also do just want to recognize that we have I did see Dr. Kalsa. He is our co-medical director of the stroke program, and Dr. Rose may also be there. He's our other co-medical director, along with Maria Nunez. She's our clinical program stroke manager and nurse practitioner for the stroke program. So I will turn it over to Joanne.
Thank you. And Dee, do you have the certificate or the award that you'd like to share on screen, please?
It's coming up now.
Thank you. While she's getting that up, good evening. My name is Joanne Pineda, and I'm the Quality Improvement Manager with the American Heart Association. Can you hear me okay? Perfect.
Yes.
Thank you for the opportunity to join you this evening. I would like to share that this is the best part of my job because I get to celebrate with you, celebrate your accomplishment, celebrate the true meaning of the award, and especially celebrate the fact that your hospital was able to maintain high quality stroke care during a pandemic year. So on behalf of the American Heart Association and the Get With the Guidelines program, I'd like to congratulate Washington Hospital Healthcare System for achieving another banner year of stroke accolades since joining the Get With the Guidelines in 2006. Tonight, there are several. First, it's the Gold Plus Target Stroke Elite Honor Roll Award for implementing Get With the Guidelines stroke. The steps required to achieve the gold level of recognition are a minimum of 85% compliance in all of the 7 achievement measures for stroke for the 2020 calendar year. The plus level requires additional data collection for a set of quality metrics at 75% or above compliance. Washington Hospital was also able to achieve the Target Stroke Elite Honor Roll, and to qualify for this recognition, hospitals must meet a minimum of 85% compliance in door-to-needle time in less than or equal to 60 minutes. Lastly, the American Heart Association is also honored to recognize Washington Hospital with a Target Type 2 Diabetes Honor Roll Award geared towards the management of diabetes treatment for stroke patients. As mentioned earlier, I'd like to thank Dr. Rose and Dr. Kalsa for their leadership as identified Get With the Guidelines physician champions and stroke program medical co-directors. Also to Kimberly Hart, Stephanie Williams, Larry Labossiere, for their support as executive champions, and especially recognize your clinical manager of the stroke program, Maria Nunes, and Michael Platzbecker for the stroke director. Get With the Guidelines also emphasizes a multidisciplinary approach to stroke care. So in addition to the folks that I mentioned, I'd like to say thank you to all the members, the neurologists, the neurointerventionists, the neurosurgeons, the stroke nurses, emergency department staff, rehab, radiology lab staff for their hard work and dedication for improving quality of care for patients. Your hospital will also be recognized in an ad in the upcoming America's Best Hospitals edition of US News and World Report. And it's now my great pleasure to present the Get With the Guidelines Stroke Gold Plus Target Stroke Elite Honor Roll and Target Type 2 Diabetes Honor Roll Award to Washington Hospital Healthcare System for your commitment to quality of care. I look forward to our continued relationship and quality, and hopefully even expanding to other programs within the Heart Association, such as Heart Walk or initiatives around community impact and health equity. Congratulations.
Thank you, Joanne. I was wondering if Dr. Kalsa
Yes.
or Dr. Rose had anything to say.
Yes. Hi, Dr. Nicholson. This is Maria.
Maria, there you are.
Yes. I would just like to say some few words. First and foremost, thank you, Joanne. It's a great honor to be receiving this award for the past 13 years in a row. I know American Heart and Stroke Association is a pioneer in striving stroke excellency with stringent and updated evidence-based practices. And of course, at Washington Hospital over here, we are very proud to be a part of this framework in improving patient outcomes. On behalf of the entire stroke team, I'd like to thank the board for your commitment and support to the stroke program, thereby strengthening the community confidence in the quality and safety of care, treatment, and services. We'd also like to thank our CEO, Kimberly Hartz, for her excellent leadership and commitment to higher standard of clinical service. Our thanks goes out to previous VP CNO Stephanie Williams for her expertise and encouragement. We look forward to continuously achieving excellence in stroke care and getting redesignated by Joint Commission due at the end of this year under the leadership of our new VP CNO, Larry Labossiere. Lastly, the medical directors, Dr. Rose, Dr. Khalsa, and Michael Platzbecker, our stroke program director. Dr. Rose and Michael were unfortunately unable to attend, and myself would like to acknowledge our frontline stroke nurses, neurologists, and the entire teams across the continuum of stroke care for their dedication and service to this program. Thank you.
Well, thank you, Maria. That's really quite an accomplishment, and I think you really focused on the fact that this is a team approach with many frontline nurses. It's amazing how great a job they do at all hours of the day and night. And I wanted to thank you for your leadership, and Dr. Rose and Dr. Khalsa and Michael for their leadership in making this team so talented and so helpful in these patients who really need great care. And I'm so glad that they're able to get that care here at Washington. It seems that every year, year after year, we keep getting awards.
Yes.
And it's thanks to your effort and the effort of everybody on your team. So it's great to see.
Thank you.
So congratulations to the whole team. And I know this accrues to the benefit of the community.
Thank you very much, Dr.
Thank you.
Thank you. Okay, Kimberly, I think we have another presentation, and I'll let you introduce.
Yes, so moving on, we have Shirley Ehrlich here. And Shirley has worked at Washington Hospital for 11 years as an executive assistant in health information management and medical records. She has also served as president of WIA, which is our Washington Hospital Employees Association, in 2011 to 2013, and returned as president in January of 2019. And she has a very special presentation that is special not only for the whole healthcare system, but also the board of directors, because it does recognize one of our past board of directors, Don Pickenpaw. And I know that for those of you who don't know who Mr. Pickenpaw was, he was the longest serving board member. He served on the board of directors, I think, for around 25 years or so. And so WIA has established a scholarship in his name. So Shirley is going to tell us a little bit about how that is set up and also announce the winners. So Shirley.
Good afternoon. Can you hear me okay?
Yes.
Okay. Thank you. He was also elected president 5 times during his tenure. Okay, so the eligibility requirements for the scholarship include the following elements. They must be a dependent of a Washington Hospital employee. They must be a graduating senior or a community college student or a student attending a 4-year institution. And lastly, they must have planned to attend an accredited community college or university or vocational school on at least a half-time basis. The application packet requires inclusion of the following items: a copy of their high school or college transcript, a personal autobiographical essay, and 3 letters of recommendation. The panel of 5 judges is made up of 3 physicians, a chief, and a director here at Washington Hospital. The 5 judges grade the students by a scoring system. Those who scored the highest went on to a panel interview. The judges then made the decision to choose the top 2 candidates for this year. Those candidates are Dev Patel, who is the son of Jigna Patel, who works in food and nutrition services. Dev graduated from Bellarmine College Preparatory and will be attending UC Davis pre-med. The next candidate who also won is Antonio Bayucan, son of Maria Bayucan, who works in our intensive care unit. Antonio graduated from Moreau Catholic High School and will be attending UCLA, majoring in English. And that concludes my report. Thank you.
Thank you, Shirley. It's so great to have these young students receive the scholarship, and it's so great that we're honoring Mr. Pickenpaw's service to this community in such a manner. You know, he was a great board member, and I remember him for his attention and focus on what is best for the community. And I think the scholarship serves that interest, and I'm so glad to see these two students rewarded in this fashion. So thank you, Shirley, very much.
Thank you.
Okay, we'll go on to our reports, and our first report is from Dr. Hyder, our medical staff report.
Yeah. Good evening to everybody.
Good evening.
Good evening. First of all is the vaccination booster dose will be starting soon, past September 20, and once it is completely available, we are going to give a date so that all the staffs get the booster dose. And there is nothing much going on as far as the chief of staff report, but I want to give the grand total of all the staff which we have is 574, which active is 346. Out of those are 346 active, and administrative 1, allied health 30, ambulatory 93, consulting 8, courtesy 25, leave of absence 6, provisional active 49, provisional AHP 14, provisional courtesy 1, relinquishment 1, and the grand total is 574. The number is a little bit decreased from last time, but otherwise it looks great.
Thank you very much, Dr. Hyder. Anything else to report?
No, the most important thing is vaccination, which will be starting soon, the booster dose past September 20. And we are going to set a date and start that.
Yes, we're all looking forward to
Yes.
that. Great. Thank you very much, Dr. Hyder.
Thank you so much. Thank you.
Okay, Debbie Fury, so good to see you back. We've missed you, but you know, Sheila did a great job while you were away, but we're so happy to see you and hope all is well with you.
Thank you. I'm really happy to be back. I want to thank Sheila, our first VP. She really helped me out a lot, taking over the last couple months. But hopefully I won't miss any more. I just wanted to get started in this. The month of August, we had 102 volunteers that contributed 1,350 hours in their assignments. The volunteers are servicing, they're adult, they're in spiritual care, and college age volunteers. We have, in accordance with Washington Hospital's visitation guidelines, we're not yet able to welcome back our high schoolers. We hope to restart the process later this year or later this fall. And we have them on a list to be calling them back. So that's hopeful. And of course, they are calling us all the time, which is good. We have the Nursing Unit Assist program has been especially active. And so we have a couple of our college volunteers that we have promoted to trainers. So they're now helping us train the new volunteers coming in that are college and adult. And so that is thriving. And so we're able to fulfill more shifts, which is really good for helping the staff and us. So we have the Service League is also busy volunteering on the COVID related activities. We're assembling COVID-19 test kits for use in the lab. We've assembled over, from year to date, 18,850 test kits. We've assembled 500 face shields in August for the clinical staff and plan to complete another 600 this month. And then since March of this year, we have labeled 35,812 vaccination syringes for the pharmacy. Then we also have our WOOF program that is restarted last month, and they visited 19 patients last month, and there's 5 teams. And to become a WOOF member, not only does the handler have to be approved, but the dog has to go through training, and they also have to go through a third-party training. So it's not just bringing in Fluffy or whatever to come and visit patients. They are trained. Overall, the Service League is halfway through this fiscal year, and we are continuing our volunteer hearts. And that's the end of my report.
Thank you so much, Debbie. It's so great to hear that the high school volunteers will be joining us hopefully this fall. I'm really looking forward to that. And, you know, I can say we're all so appreciative of the great work that was done by the Service League in supporting the vaccination clinic. I know you guys are going to ramp things up again as we get the booster shots out. And so just so much appreciation for that great work. It's really so helpful, and it really helps to protect our community, everyone within it, and everyone at the hospital as well. So thank you for all of that work.
Thank you.
Great.
Thank you. We really appreciate the hospital also. Thank you.
Great. Thank you, Debbie. Appreciate that. Let's see. Our next report is our quality report with Dr. Martin. I don't see her on as yet.
Okay, I can give.
I'll check with her.
Okay, I'll give her an overview, and Mary Boron can. I think Mary Zahn can check to see where she is. I think we all know Dr. Diane Martin, and she has a very timely report for us this evening. She's going to be talking about the influenza season this year, along with giving us a COVID-19 pandemic update. And Dr. Diane Martin has been an integral member of the Washington Hospital's medical staff since 1984. Dr. Martin has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection control. She has been a physician champion for our 5 Million Lives campaign, where she analyzed data and educated her peers on infection control issues, and specifically MRSA. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine, and she serves on the board of directors of Life Elder Care, and she is also a member of Washington Township Medical Foundation. So, Mary, are you able to see if Dr. Martin can come on now?
She did.
Or we can...
Yeah,
Okay.
she did tell me that she is having some Zoom difficulties, but she's just going to call in by phone.
Okay.
I'm on.
Okay, great.
Perfect.
Good to hear you, Diane. Welcome.
Oh, yay.
Yay.
Thanks, Dr. Martin.
Okay. So I'm on by phone and I can see the slide set. So I'll just, if Dee doesn't mind driving, I would be very appreciative.
Yes, we'll drive.
Got it. Okay. All right. Okay. So this is a combo talk between talking about our influenza season and our COVID pandemic. So we saw very little flu last year, multiple reasons. And so we still want to tell people about the flu. So we want to present the information here. So last year, I think is because of the masking and the isolation, probably just did not see as much flu. I don't think we can assume that as I'll go forward, because we're starting to see surging again in COVID. And so I think the flu is very important, and getting the flu vaccine is also very important. Next slide. Can you advance the next slide?
Yeah, we're there.
Okay. Okay, I guess I'm just not seeing it. Okay, I'll drive on my end. Okay, one sec. Okay, so similar to the prior influenza season, we're not quite clear what the impact of COVID-19 will do, but we're obviously very, very concerned about it and want to make sure that people still get their influenza vaccines because this is critical. There are times where we're going to see both viruses circulating, and I know that the ER will definitely know that when they are seeing a patient who's quite ill, trying to sort out the difference between an influenza, a norovirus, or SARS would be quite difficult. We do have testing available that helps us sort that out, which is very important for our ED staff because people may actually be co-infected with both. Next slide. So influenza and COVID-19 are both very contagious respiratory illnesses, but they are different viruses. They are actually both coronaviruses, but the COVID is specifically one that we're going to talk about as a coronavirus and the influenza separately. Both can have very similar signs and symptoms: fever, chills, cough, short of breath, fatigue, sore throat, runny nose, muscle aches, headaches. And some people, even with influenza and or COVID, can have nausea, vomiting, and diarrhea, although we do see that more in children. We have seen some of this in our adults that presented specifically with vomiting and diarrhea that we thought was foodborne illness, but when we checked for COVID, the COVID was also present. So I think we just can't assume one versus the other. There's possibly to have both, and they can present very similarly. Both are spread by droplets when an infected person coughs or sneezes, because these are respiratory transmitted. So people can be infected by touching an object or a surface that has the influenza or the COVID virus, and then when they touch their own eyes, mouth, nose, that's how it's spread. I mean, many of you probably have seen the backlit of a cough. You can see the projection of the droplets. That's very, very similar in both the influenza and the COVID. Patients can also be infected with other kinds of infections at the same time as they have either flu or COVID. They can have bacterial infections such as pneumonia, sepsis. They can have neuromuscular complications like we see with muscle weakness, sometimes mimicking stroke. Lung complications can exacerbate asthma or COPD. Many of them show up as cardiac symptoms. They're having chest pain and may actually have other symptoms that look like it's myocardial infarction when it's primarily the flu or the COVID. And obviously both are high risk for being hospitalized and very high risk, unfortunately, for mortality. So just to tell you kind of what is a flu shot. So the vaccine is developed from antibodies that provide protection. And we actually build up from year to year, having had the influenza the year before. Your body starts to see these major strains of the influenza A and B and will start to build up antibodies. Generally, there's very specific strains that are present from time to time and season to season, and that's how we select the ones that are going to be incorporated into the influenza virus vaccine. Currently, we have 2 influenza A and 2 influenza B, and those are already circulating mostly in Europe and other areas, and we usually don't see much of this until probably December for California, but we want to give the vaccine now because at times people travel. We also want to be well protected ahead of time. So the next slide. The flu vaccine is recommended for anybody 6 months and older, specifically for our essential workers, such as our healthcare personnel, physicians, doctors, but also our support staff. It's very important that they get vaccinated. We also want to include like long-term care facilities and pharmacy staff and other infrastructure workforce. I mean, we certainly couldn't do without our environmental services, nor our technicians or our IT people. So we would want everybody vaccinated. Specifically, people who are very high risk are those that are 65 and above, residents in skilled nursing facilities or other congregate living. and also individuals who are immunocompromised, whether or not they have asthma or they have chemotherapy or they've had a transplant or dialysis. And then certain racial and ethnic minority groups are also disproportionately affected by COVID. We see this primarily in our Hispanic population in California. I don't know that that's been well explained, but unfortunately that demographic group seems to be very severely affected. Persons that are high risk for influenza include young children, infants, children who have neurologic conditions, pregnant women, adults 65 and older, and other people who have other underlying medical conditions, such as asthma, diabetes, renal failure. There are certain high-risk individuals who should not get the vaccine, and that would include people who have had severe or life-threatening allergic reactions to influenza vaccine, or what's called Guillain-Barré syndrome, where it basically starts up a neurologic inflammation in the system, and the person can have paralysis, and including respiratory paralysis. So anybody who's had that, we strongly recommend that they should not have the vaccine. Next slide. So people ask questions, does the flu shot work? And it does work. It's, again, not like everything else in the world, nothing's 100%. So people who do get the flu shots, as well as people who get the COVID shots, they have a much lower chance of getting more seriously ill than someone who's not had vaccine. So the vaccines are not 100% protective, but hopefully just with the COVID and with the influenza, if a person is vaccinated and they do happen to get infected, their illness is much less severe and potentially not needing to be admitted and not basically being in an intensive care unit, and hopefully freeing up those beds for somebody else that might be more severely ill. So do we need to get the vaccine every year for the influenza? And the answer is yes, because this virus, just like the COVID virus, and I'll get to that in a little bit, does mutate. So the vaccine strain does change from year to year with the influenza. So the vaccine from last year to this year is going to be a little bit different. Because of that, you do need to get the vaccine every year. We do recommend that vaccines start by October. The vaccines are effective throughout the year. It generally takes about 2 weeks to get an immune response. And again, sometimes we push ours out a little bit later to late October because most of us in California do see our influenza season coming like in early January or late December. Initially, when people are traveling back east for holidays and things, they would want to get the vaccine much earlier just so they are protected. Next slide. So can the vaccine give you the flu? No. There's no live virus. It's only an inactivated virus in the influenza vaccine. So there is also what's called a recombinant or attenuated. So it's not developed in the egg. So people who are like egg allergies, this would be safe for them. But neither one of these have activated or live virus. It's inactivated virus. So people say, well, why don't I feel good after I get a flu shot? Well, it does give you side effects that are very similar to the flu, such as body aches, probably a low-grade fever, soreness at the site of the injection. But those just show that your immune system is working. It's registering that this virus is there. It's registering immune responses that are going to start triggering and will be ready for when somebody does get influenza. In rare cases, people can have symptoms that last for 3-4 days after the vaccine, but that's quite rare. Most of the time, it's 24, 48 hours. And obviously, the symptoms are considerably less severe than somebody who actually gets the flu. So the next slide. So with what Washington Hospital is doing to reach out to communities, healthcare workers, and our inpatients is we're screening and vaccinating all eligible inpatients. Flu shots are available for inpatients. We have mandatory vaccination or proof of vaccination for healthcare workers. Per Alameda County, if someone does decline, for example, if somebody who's had Guillain-Barré, then there is mandatory masking required for our healthcare workers. We also, at Washington Hospital, are very proactive in providing preventative measures. We have hand hygiene dispensers everywhere throughout the hospital, throughout any of the organization areas. We do require universal masking and eye protection policy. So we also, from time to time, do look backs to see where we are, what's happening, and where the future directions are going. So we have annual analysis of employee vaccination rates. I'm very proud that Washington Hospital has been in the high 90s almost every year. We do quarterly evaluation of patient vaccination rates throughout the season. And through the ED department, we are monitoring patients who are coming in with influenza or flu-like or viral syndrome presentations. Next slide. So you might say, well, what are we doing to prevent things? So when we are for COVID, so we're screening patients who come into the facility, whether they're coming in as visitors or healthcare workers or anybody who is coming into our facility or getting screened. Either they have to present proof of vaccination or proof of a negative test. For any of our patients who are getting admitted, we do immediate isolation of anybody coming into the facility who is symptomatic and or looks to be high risk. We do universal masking for everybody, including our patients. We provide masks on every patient, on every unit, and strongly encourage that they use it. Obviously, if they're brushing teeth or eating, no, but the other 99% of the time, yes. We've been very proactive in working with the county to do safe, restricted visitor policy. And this, again, requires proof of vaccination or a recent negative test. They are making some exclusions if somebody's coming in for births, pediatric visits, or end of life, because obviously may not have the time to prepare adequately. All of the elective surgeries mandated COVID testing. All patients who are being admitted are tested for COVID. It's been somewhat interesting for me to see patients coming in with what look like stroke-like symptoms. They're getting admitted, and we're doing testing, and they're positive. So they have very minimal symptoms for COVID, but do have COVID. And some of these, after they're admitted, do go on to become a little more ill. We are in close contact with the local skilled nursing facilities. Wendy Lamb from our case management coordinates with all of them on a very regular basis, and we also reach out to Public Health Department. Public Health Department has ongoing sessions every 2 weeks giving us updates on activity of the virus, what's going on, what's the availability of vaccines, and multiple areas of information to share. Next slide. So this is our healthcare personnel information. They are all offered the COVID and influenza vaccine. For our last year, 96% of our staff received the vaccine during that season, and 91% to date of the staff have received the COVID vaccine. We have another 47 that are partially vaccinated in the process of full vaccination. Some of the ones we've not outreached to are people who are on leave of absence or ill or away or vacation. So we are working diligently to work with them. I know the HR department is reaching out to them just to make sure that they know that vaccines are available, and we strongly support getting vaccines. We are doing ongoing education and support for our staff whenever they have questions or concerns about the vaccines. Next slide. So this comes up quite often as the COVID variant. So people want to know, well, what is a variant? The viruses, just like the influenza virus, change through mutations because they are adjusting to what's going on. And they do change to make, the virus changes to make itself more stronger, more aggressive, and more resistant to anything interventions we've done. This is also true of bacteria in terms of antibiotic resistance, but we see this very actively going on with viral infections, and specifically the COVID variants in the United States, and I'll show you a list of them in just a minute, are being monitored through gene sequencing. So there are several laboratories at UCSF who's doing very aggressive gene sequencing. Alameda County has their reference lab, and also through our individual Washington Hospital lab, we have a reference lab that we can send out to get gene sequencing. So this helps us in epidemiologically to try to see where things are going. So many of these are classified as a variant of interest, where it may be notice, but has very little impact on changes to the way the patient's treated. So it doesn't reduce the efficacy of a treatment, doesn't change the diagnosis. So these are more of interest. The ones that are of concern, and the current one we're working with right now, is the Delta variant. So this one has shown that it's much more aggressive in terms of transmissibility. When someone gets sick, they are more severely ill than someone who does not have the Delta variant. And there's also much higher risk for needing ventilator support and death. So there's also variants of high consequence, which has clear evidence that preventative measures have been significantly reduced to prevent any of the circulating variants. We have not seen that as yet. So these are a list, next slide, a list of the current variants of concern in California. The primary one is the Delta variant, which is the B16172. The one I want to present to you next is what's called, well, sorry, one more slide. So this very dramatically shows you, so the orange one, the B161.7.2, is the Delta variant. So you can see starting in June of this year, because those, I don't know if you can see on the bottom, it's got the dates on the bottom. It's a little bit grayed out, but those are the dates. So going from right to left, it's going through June through first week of September. So you can see the orange band greatly taking over, and that's the Delta variant. So we're seeing much more of the Delta variant, much less of the other variants. And then the one that we're concerned about now, next slide, is a new one that's a mu variant. And this is another coronavirus. It's being evaluated. We're seeing it mostly in South America. It's increasingly aggressive in terms of new cases and affecting people who have been vaccinated, as well as people who have not been vaccinated. So the mu variant is being very closely monitored in the United States, not so much in Alameda County, but we're aware of it because the Delta now, is that previous slide shows you, is about 99% of our dominant variant. Next slide. This is a little bit of a busy slide, but just to kind of show you, Alameda County is on top of everything. We are monitoring the number of vaccinated, the residents who have had at least one dose, how many have been fully vaccinated, the strain that we're seeing, and information across the board. So I know it's like really busy, but to tell you, Alameda County, we are working very hard to keep track of this virus. Next slide. So this is going back to the vaccine update. So it's recommended for persons that are 12 and older, including women who are pregnant, breastfeeding, trying to get pregnant, or considering pregnancy for future. The vaccines are authorized in the United States to be remarkably effective to reduce severe disease, hospitalization, death, and even some against the circulating Delta variant. What people are now interested in, so a lot of people have gotten both doses of the COVID vaccine. We're looking at what's considered a booster shot, and this has been approved by the FDA for moderately or severely immunocompromised people. And this would be patients who are on chemotherapy, patients who are on immunosuppressive drugs. We do think that this will provide additional benefit to those patients because their immune system may not have appropriately responded to the first two doses. So the booster or third dose will definitely help their immune system. And again, preventing, hopefully, if they do get sick, much less. Washington Hospital is in the process of working with Alameda County and also CDC guidelines to offer the booster shots this fall. And they are currently approved for both the Pfizer and the Moderna RNA virus vaccines. Next slide. So there's also considered additional doses for patients who are immunocompromised, and then the booster, which would be people who should get the third dose. And we're again working with CDC and FDA to make sure that we can get people vaccinated with a third dose. We're anticipating this for possibly September to maybe October. A lot of it's ramping up with what we're already doing. At the same time, everybody's doing influenza vaccines, so we're certainly balancing a lot at one time. Ideally, somebody should get the third dose 8 months after the second dose. I know many people were vaccinated in December, January, so we will probably not make the 8 months recommended timeline, but they are still recommended even if it's your 10th, 11th, or 12th month to get those follow-up vaccines. So people say, well, what can I do? Well, number one is definitely get that COVID vaccine. That is very, very important. You want both doses, and when the third dose, the booster dose is available, you certainly want to sign up for that. Currently, Washington Hospital is having this available, and then the following slide will give you more information on that. We're strongly recommending the flu vaccine, and we are currently giving out flu vaccine. The next slide will show you that. The other thing you could do is, if you cough or sneeze, try to cough or sneeze into your elbow, wash your hands as much as you can, try social distancing, elbow bump instead of shaking hands. If you have a regular cloth mask, wear it. Try not to wear it without washing it in between, or if you have the disposable ones, try to swap them out at least every day. If you're coughing and sneezing into it to where they get a little bit damp, then the integrity is not as strong. So again, change out the mask. If you do get sick, please come in and let us check you. Either phone your primary care so that they can help direct you, or if you're super sick, then in the ED. But if you're coming into the ED, please alert them that you think you might have COVID. They will certainly appreciate that. So here's the vaccine information. The COVID vaccine does require an appointment. There's an online link. For those of you that have signed up through MyChart, it's a very easy access. If not, you can call the vaccine phone line, which is 510-248-8200. We have a huge staff that will answer really fast, and will get you signed up for your COVID vaccine. The flu vaccine is currently in progress. It's a walk-in at the 2500 building, and it's 11 to 4 weekdays, and Saturday, Sunday, 12 to 4. You can make an appointment. And I guess if you're coming in on Saturday, Sunday, you might want to make an appointment, but an appointment's not required. We do take the walk-ins. I think that was my last slide, so I will take questions.
Thank you, Diane. Any questions for Diane? So Diane, I have a question on flu vaccine. Can you hear me?
Yes, I can hear you. Thank you.
Okay, good. So the flu vaccine comes in different variations. And if somebody has the opportunity to make a choice, do you have any specific recommendations?
Well, we have the regular flu, which I would say for most people in their 20s and 30s is probably acceptable. We have a quad, which is the 4 strain, and also a high dose quad. So somebody who has ongoing medical issues, whether it be asthma, COPD, ongoing dialysis, chemo patients, or people who just really feel like their immune system's not as strong as it used to be, might want to ask for that. And currently Washington Hospital is carrying that. I know many of the pharmacies also carry it. So I'd say ordinary people, 20, 30 years old without any existing medical problems, probably the regular flu is fine. For those 65 and above, probably you want the high dose and the quad, which is the 4 strain.
Thank you, Diane. I also have a question on COVID in the pediatric population. The schools are open, and I'm getting a lot of questions from parents and families about what we're seeing, especially with respect to the Delta variant in the pediatric population. Can you shed some light on what's happening in our community?
The schools are just starting to open, and I think that we are looking closely along with Alameda County to try to see if we can follow what's happening in the schools. Obviously, they're working very hard to get the Moderna passed for the 5 to 11 years old, but right now everything is just 12 and above. But I think that, I think the schools are very aware that they want to keep the students healthy, and they're doing things on an individual basis, whether it's cleaning or hand hygiene or masking, to try to, and social distancing to try to maintain the health of not only the teachers, the staff, but the students, because we obviously don't want them becoming ill and then coming home and maybe secondarily infecting their family.
Do you see any evidence that either the Delta or perhaps the Mu are affecting or will be affecting the pediatric population more than the Alpha?
The Mu is very new, and I have to say we don't have that much information on pediatrics. The Delta does affect the children, and it's the same increased transmissibility, infectivity, and severity of illness with that strain.
Great. Thank you, Diane. One final question.
Yep.
Oh, go ahead, Mike.
Okay, Dr. Martin, I read in the Chronicle this morning, or maybe it was yesterday, that for kids in school, they don't recommend a cloth mask, and you were suggesting the preferences for a cloth mask. The article in the Chronicle was saying that they should wear, I guess, the surgical mask rather than a cloth mask. So.
The cloth mask, if they're talking.
I think they concluded that you should wear both masks. So, but go ahead.
I'd have to say I didn't see that. Usually we don't do two because it changes the integrity. I can see maybe they feel like the effectiveness is longer lasting with the other one, because if you're talking like children are doing, answering questions in class, then they may get the mask wet, and that also is causing more accessibility for virus to get through the mask than if the mask is dry. So maybe that was the other reason they suggested two, is just increased barrier protection. But I'd say the bottom line is whatever vaccine you can get, take, and whatever mask you can get, take. Because obviously prevention is
Thank you.
far above anything else. Thank you. Good question.
Sounds like really good advice, Diane. Keep protected and stay
This is
protected.
Bernie. I also had a question. I'm going back to the flu vaccines, the quad and the high dose. Is there a preference between those if you're over 65, or it doesn't matter? I don't quite understand the three kinds of flu vaccines.
So the ordinary vaccine just has the 3 strains, and the quad has 4 strains, and the high dose has just a higher concentration of all 4 vaccines. And I think the one that we're currently carrying with the foundation and with the vaccine clinic is the quad high dose. So it does cause a little more reaction when you're getting the shot, in terms of like maybe a little more in terms of fever or achiness or soreness at the injection site. But to me, that's well worth the increased protection that's afforded by that vaccine.
Thank you very much.
Jeannie, Jacob, any questions for Diane?
No, thank you. Go ahead.
That's right. Yeah. The school district, I think, they do have a website where they're documenting all the cases. Fremont School District has one.
Okay.
Not too many cases. I think 40 or 50 cases, but mostly among the elementary school. High school is much less. But the explanation could be that most of the high schoolers hopefully have taken the vaccine. But I think every school district has got a website which monitors that. But certain states, as you know, that in Florida, a week after school opened, there are 20,000 cases among children, and 5,000 teachers were affected. Of course, masking, people don't wear much of masks there, and vaccination uptake also was low. So, that probably could explain that. But there are pockets around the country where outbreaks have been a little more common. I think even there was a story about the teacher in Marin County. Apparently, half of the class or the students were positive, because she had COVID and she had taken out the mask to read, text loud. And after classes tested positive, and she was not vaccinated. So, there are stories that's going on. So we might see pockets of outbreaks.
Yes. I think the counties are trying to track that, but your information is very good.
Dr. Martin, this is Jeannie. I just want to thank you for the information. And did you say that Moderna was approved for third dose?
I think they're working on it. It's really,
Okay.
really close. So I think the Pfizer for sure and the Moderna is very close.
Okay. Thank you.
And Diane, this is Bill Nicholson. One last question. Where did the September 20th date come from? And do we have legitimate reasons to expect we'll get a specific recommendation on that date?
Hope springs eternal.
Okay.
Bill, I think that's the debate that's going on. I think this 20th number came out from the administration. And now, FDA and CDC is saying, who said that number? We didn't say that 20th. And so that's a big debate that's going on. And so it may not happen. The official declaration of the date may not happen on the 20th of September. I don't think so. Because now it's all between administration and FDA and CDC.
Thank you for that, Jacob. So we should be prepared, but not hold our breath.
Right.
That's it. I find that interesting. I heard of dentists up in Oroville getting third shots, and yet we're understanding that it's not approved yet. Is that accurate?
Well, they're looking at it for patients who are immunocompromised, but there are a lot of the patients or people are getting it from the pharmacies, and they flat out told me I want it, so I told them I had this, that, and the other, and they didn't get questioned and they got it. So, I don't know what to tell you.
So it's if you're immunocompromised, you could get it now.
Yes.
A lot of the pharmacies are doing it.
Yeah, Bernie, and on this, there's a lot of places there's no questions asked. If you go and say that I need a booster dose, because a lot of my doctor friends in Southern California, they just walk into CVS, no questions asked. They've all got boosters.
Yeah.
Mary, this is Kimberly. We have, as the healthcare system, just to be clear, we have to wait, of course, until we've gotten the approval through, it comes to the FDA, and then I assume CDPH will then provide vaccine, and we'll go through those channels, correct? As we are that's how we receive our vaccine.
Exactly. So
Right.
at this time, the healthcare system is following the exact guidelines based on FDA approvals. And so once the FDA approval comes through and CDPH supports it, which is likely to happen hopefully sometime by the end of September, but again, we're not set on those dates exactly, then we would offer it. We're just following the exact guidelines. And I think the point that was mentioned earlier about how you can potentially get it in other pharmacies is they ask the questions in the screening, but do not verify for supporting documentation. So of course, some people have been able to use that to advantage and get the booster. Currently, we're just following the actual guideline nationally and statewide.
I have another question, and I think I've asked this before, but now I forgot the answer. Let's say we get the booster on the week of September 20th. And at the same time, I've heard that they're formulating a new vaccine that's targeted for the Delta variant. What is the advice, if you've gotten the booster in the week of September 20th, about your ability to be able to take the targeted Delta vaccine, say in October, November sometime?
What I would imagine, this is Mary, is that, and Dr. Martin, you can probably add more to this, but it will, at the time, if those line up, as in the example that you explained, there will be guidelines which we can follow at that time to see what we would do for the cases that just received it if a new vaccine comes out that's specific to Delta. Right now, the CDC is strongly standing behind the current vaccines for having the majority of coverage on Delta, especially avoiding hospitalizations and mortality. But I do think they would give specific guidelines in that scenario.
No, because I get the question that I don't want to get the booster because I'm waiting for the special sauce that is aimed at the Delta. So that's the basic question about that I get. So
I don't think we know the timeline.
I guess
for
the answer is get the booster. So,
I mean,
okay.
I would just go ahead and get the booster because we don't know the timeline for the other one, and it may or may not be as strong as we would like to see it be. But I would say the boosters look like they're very beneficial, and I'd say that's a start point, and we can reevaluate when we get more information on the Delta booster and see what that's going to look like or how it's going to get marketed, or if it's available. It's going to be very tightly controlled. Maybe it's not going to be as widely available as we would like.
Yeah, I don't believe that the vaccine trials on the Delta has completed, and certainly it doesn't have an emergency use authorization as yet. That would be the first sign that it may become available, and that's probably months away. So I think the bottom line is get the booster as when you are eligible for it and it becomes widely available.
I also had a question about the two vaccines, the flu and the COVID. Do you have to separate those? Is it best to go a little while between them? Can you get them both at the same time? What's our feeling on that?
So the FDA and CDC have said that you can get them both at the same time. So we have in this community, enough supply to where you could space them a week to 10 days apart, which would probably be ideal. But obviously, if you are somebody in an underserved area or there is very limited access for getting the vaccines, by all means, get them both at the same time and be protected. In the Bay Area, we have more leeway in terms of being able to space them apart, and we encourage that. But if need be, the FDA and the CDC have both said you can do both at the same time.
Thank you.
You guys have had great questions.
The concern I think comes, I think even a lot of our staffs in the clinic, they're all looking for boosters, because there was just a study about 4 or 5 days ago from Belgium, which compared Moderna and Pfizer. And what they found out was after 3 months, the antibody response for people who have had Pfizer was sitting around 6 to 7%. So at 8 months, the question is, do you have any immunity at all? So that's why I think when people read these kind of reports and studies, they always are anxious and want to get this boosters. So.
Yes.
Well, let's hope the FDA and the CDC take quick action and that the boosters are widely available. I appreciate the lively, pertinent discussion, and hopefully by the next time we meet next month, we'll be well underway with our boosters. So thank you very much, Diane and Mary, for that very important discussion. Appreciate it.
Okay. Thank you for the support.
Thanks, Dr. Martin.
You all have given our hospital. Really, really appreciate the board's support, and hope all of you are going to be safe.
Yeah. That's the bottom line, is keep safe. You can't rely on the vaccine alone. Mask up, keep your distance, use all the precautions that are appropriate for somebody. That's right, Jeannie, wash your hands. Yeah, use all the precautions. Great. Well, thank you very much.
All right, take care. I'm going to sign off.
Okay, great. Thank you, Diane.
If
Okay,
somebody
well,
has questions, tell me or Mary. Okay?
Okay.
Thanks.
Great. Okay, we'll now move on to our finance report with Chris Henry.
Okay, thanks, Dr. Nicholson. Tonight we'll be looking at the operating and financial results for Washington Hospital for July, our first month of our fiscal year. Looking at our acute inpatient statistics. Our inpatient average daily census for the month came in 10.8 below budget at 134.8. Our combined average daily census, which as you recall includes our outpatient observation days, came in 5.9 under budget at 145.9. So a heavier load in observation as we've seen the last several months. Admissions for the month came in 36 below budget at 811. Our patient days were 334 off of budget at 4,180 for the month. Our outpatient observational equivalent days, however, came in 152 higher than budget at 344. And our average length of stay for the month came in at 4.85. We'd expected 5.33 in the budget. So fewer people in the hospital and staying shorter than we expected. Operating indicators, our case mix index for the month, this is an indicator of that shorter length of stay, lower than we expected in the budget at 1.582. I think that's one of the lower case mix indexes we've seen over the last year or so. Deliveries for the month came in 3 off of budget at 126. We had 4 more surgical cases than we expected at 391. Oh, sorry, do I need to, oh,
yeah.
Sorry, no?
There, it's, no.
What's happening here, guys?
We can see it now, Chris.
Oh. There you go. All right.
Okay, do you need me to start over?
No, we're on the utilization statistics.
Okay, I left off at surgical cases.
Yeah.
Cath lab cases for the month were 52 below budget at 179. Our outpatient visits came in at 7,476. We'd expected 7,612. I do want to say on the outpatient visits, we did have a downtime with our computer systems right at the very end of July, and that resulted in us having to reschedule a number of our outpatient visits into August. So I think when we get into August, you'll see those numbers are higher than we expected in the budget as a result of pushing some of those patients into August, unfortunately. Emergency visits for the month came in higher than we've seen for a while, at 607 visits, higher than budget at 4,434. Looking at the detail of our surgical and cath lab cases, surgical cases, joint replacement cases were 4 below the budget, but those were offset by cardiac surgical cases and general surgical cases that were 8 above budget. So we end up again with surgical cases 4 higher than budget overall. Cath lab came in below budget and really lower pretty much across the board. The largest variance we see there coming from non-vascular interventional radiology. Our neurointerventional radiology procedures, or cases, sorry, we're not talking procedures anymore, we're talking cases, were 1 above budget at 5. Looking at productivity, pretty good story here for the month. Productive FTEs were 53.8 below budget at 1,237.2. We had 223 non-productive FTEs, 25.5 above the budget. We got some people going out on summer vacations, hopefully there. So we end the month with total FTEs coming in 28.3 lower than budget at 1,460.2. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in positive against budget at 6.38. We had expected 6.83. Moving into financials. Gross patient revenue for the month came in pretty much right on budget. It's hard to get closer than this. They had $185,058,000, about $36,000 higher than budget. Our deductions for our contractual allowances and for provision for bad debt came in higher than budget at 78.53%. We'll look at the details of that here. Really, this month is a story of our provision for bad debt and charity. As you can see, our contractual allowances came in pretty much on budget. When you look at the percentage variance, they were pretty much in line with our gross revenue, a little bit higher. But really, the provision for bad debt and charity much higher than we expected in the budget. As you recall, our private pay as a percentage of gross revenue in the month came in at 2.5% versus a budget of 1.9%, and that really pushes that number up. So our provision for bad debt and charity, $1,751,000 above budget at $5,234,000. So again, that gets with our total deductions about $2 million higher than budget when you add in that $299,000 from the contractuals at $145,333,000. Moving into operating expenses. Operating expenses was a good story for the month. Came in about $928,000 lower than budget. Major movers there were our salaries and wages were lower by $463,000 with our lower FTEs. Benefits were below budget about $288,000, largely driven by our health and welfare claims. Supplies down about $123,000. We got some offsets there. Of note, gloves were $62,000 higher than budget. I think we're not seeing pricing coming down quite as fast as we had hoped, and with the COVID spike, our usage is again going up. So hopefully we'll see those come down later in the year when we get through this current spike. Pro fees and purchase services were below budget, $124,000, largely driven by legal, consulting, and hospitalist services. And then our utilities and insurance, utilities, and others category, this is the one area where we were above budget. That was above budget by about $109,000. It was largely driven by marketing costs. We do have a timing difference in rolling out our maternal child health marketing campaign, so that's driving that variance. So we end up the month with an operating bottom line just above break even at $19,000, about $1.1 million below budget. About $1.1 million below budget. Again, largely driven by that provision for bad debt and charity. Non-operating income for the month came in at $384,000. We did have a $359,000 unrealized gain on our investments, and then several offsetting variances, as you can see in that category. So we ended the month with a total bottom line of $403,000 against a budget of $1,327,000, about $924,000 lower than we expected. But had that provision, had that private pay been in line for the month, we would have had a pretty good month here. Moving into our Financial Accounting Standards Board presentation, and this is the presentation of how the financial markets might adjust those GASB financials we just looked at when they're looking at us. First thing we do is reclass our revenue bond interest expense of $576,000 out of the non-operating category. FASB wants those up in operating expenses. So when we do that reclassification, we end up with non-operating loss for the month of $557,000 from a FASB perspective against a budget of $541 positive. The next thing we do is we eliminate our GO interest expense and the related tax revenue that supports the debt service on those GO bonds, and we remove that unrealized gain on our investment. FASB doesn't recognize any of those three things. So we end up with non-operating income from a FASB perspective of $315,000. We end up with a total bottom line showing a $242,000 loss against a budget of just above $1 million. So are there any questions there?
Yeah, Chris, I have a question about our observation equivalent days.
Yeah.
What do you, they're substantially higher than budget. I think they were like 80% higher. What's driving that?
Yeah, it is and Mary, if she's still on, can probably speak to this better than I can, but there's a concerted effort to make sure that our patients are not being admitted when they don't need to be, and that they're in the right level of care for what they need. And we did budget for an increase in this. We're actually seeing those numbers go higher than we expected as we start to actually implement these things. And that's really what's resulting in that. It's really about having the patients in the right level of care, not admitting them over the weekend and, until Monday, just making sure they get the services they need and either make a decision on admitting them or discharging them.
Thank you, Chris. So it sounds like that's the result of effective management of the admissions versus observation process.
Yes, yes. Okay, so let's quickly take a look at our Ebitda, our earnings before interest, taxes, depreciation, and amortization. The first thing we do when we look at Ebitda is we look at our operating expenses before depreciation expense. So we pull that depreciation out, that $4,052,000 you see about mid-page there comes out, and we end up with Ebitda of $4,071,000. The next thing we do is we go down to the non-operating section and we carve out the interest expense, and we see other non-operating income and expense there net of $2,121,000. What this tells us is that our operating and non-operating activities generated about $6.2 million to fund future depreciation, to fund our debt service, our capital needs, and future program development. So are there any questions on July? Okay.
I think we're good. Kimberly?
All right, I am going to present the numbers for August. As you will see, we had a very busy month in terms of August, and September so far is continuing to be busy, but let's go over August. So the gross revenue of $207.2 million for August was above budget by $26.4 million or 14.6%, and above August of 2020 by $35 million or 20.3%. Our inpatient gross revenue of $128.5 million was above budget by $8.3 million, 6.9%, and $11 million or 9.4% above August of 2020. Outpatient gross revenue of $78.7 million was above budget by $18.1 million or 29.8%, and $24 million above August of 2020. It should also be noted, and I know we just talked about COVID, we had 69 COVID-19 discharges in August, representing 8% of our total discharges. This represents an increase compared to the prior 5 months of 24 discharges per month since March of 2021. And so we are seeing increasing number of COVID positive inpatients. All right, moving on to key statistics. Our average length of stay of 5.59 was above the budget of 5.24, so you can see our length of stay did increase. It's above budget by 0.35 or 6.7%. It is shorter than the August 2020 length of stay of 5.75. Our patient acuity, particularly our Medicare patients, was high in the month, which was driving this length of stay increase, one of the reasons. Our outpatient observation days were 118 or basically 60% above budget at 315 days, and were 142 above August of 2020. Our inpatient census, daily census of 163.3 was above the budget of 142.7 by 14.5%, and was 1.9 below August of 2020. If you looked at the combined average daily census, it is 173.5, which was above the budget of 149 by 24.5 or 16.4%. It should be noted in general, our COVID-19 patients have a higher acuity and a higher length of stay. In terms of the average length of stay for those 69 COVID-19 discharges in the month was 7.8 days. In August, there were 11 discharges with length of stay greater than 30 days. They ranged between 31 and 56 days. So if you take out those long length of stay, those 11 discharges, we were at about 5.2. We still do have in-house at the end of the month 6 patients with a length of stay that's over 30 days that we're continuing to either get placement for them if they're ready for discharge. So that's where the stand in terms of length of stay. Moving on to admissions, our admissions were above budget by 14 or 1.7%. Our higher admissions for the month were partially offset by the increase in observation days. Admissions for the month were 16 or 1.9% above August of 2020. Patient days, our admissions were above budget, as I mentioned, by 1.7%, and length of stay was higher than budget by 6.7%. This resulted in patient days of 5,062, and this was above budget by 14.4% or 639. We had a busy surgical month. Total surgeries in August of 422 were above budget by 47 or 12.5%. Surgeries were 74 above August of 2020. Our inpatient surgeries were 19 or 10.4% below budget at 164 and 11 or 6.3% below August of 2020. Our outpatient surgeries were 66 or 34.4% above budget at 258 and 85 above August of 2020. What we're really seeing is that continued shift in joints from inpatient to outpatient, and it really is continuing at a higher rate than we had expected, and both what the hospital and our physicians did expect. In the month of August, only 12% of our total joint replacement cases were inpatient compared to 37% of what we had budgeted. Also, 3 of our 30 neuro cases were outpatient cases, also adding to the number of outpatient, and we had budgeted 1. Looking at the breakdown of our surgical activity, here you can see our joint replacement surgical cases were above budget by 20 or 13.4%, and were 41 or 32% above August of 2020. We had a busy neurosurgical month. The cases were above budget by 9 or 42.9% at 30 cases, and they were 6 above budget, above August of 2020. Cardiac cases were below budget by 3 or 21.4%, but were 6 above August of 2020. And then other surgical cases were above budget by 21 or 11% and were 21 above August of 2020. Looking at our cath lab cases for August of 2020, cath lab cases for August of 220 were 6 or 2.8% above budget and 39 above August of 2020. Our cath lab inpatient cases for August of 124 were 4 or 3.1% below budget, but 10 above August of 2020. And lastly, cath lab outpatient cases for August of 96 were 10 or 11.6% above budget and 29 above August of 2020. Looking at the breakdown of the cath lab activity, our cardiac cases were above budget by 18 or 23.4% and 4 above August of 2020. Non-vascular interventional radiology cases were below budget by 15 or 19.2%, but 10 above August of 2020. Peripheral vascular cases were above budget by 2 or 3.6% and 26 above the same period last year. Lastly, our neuro IR cases were above budget by 1, 33.3%, but 1 below August of 2020. Looking at our deliveries, for August of 120 were below budget by 16 or 11.8%. And deliveries were 2 or 1.6 below August of 2020. So we went up, but then went down a little bit this last month. Moving on to our non-ER outpatient trend. Non-emergency outpatient visits of 8,284 were above budget by 751 visits, or 10%, and were above August of 2020 by 22.3%. I think if you remember, Chris noted that we did have a computer downtime at the end of July, and some of our scheduled appointments in lab and x-ray were rescheduled for August, so that was also driving some of the increase. Lab visits were above budget by 355 or 11.7%. Our cardiac rehab visits were above budget by 163 or 32.9%. This is due to some new nutrition classes that were also being provided. Our x-ray visits were above budget by 125 or 7.5%. And our respiratory visits were also above budget by 61 or 48.4%. Our emergency room, as you can see, has been exceptionally busy. Emergency room visits of 4,627 were above budget by 877 or 23.4%, and were above the same period last year by 932 or 25.2%. It should be noted, basically, this month it represents about 103% of our pre-COVID level. So we've now, in August, we're above where we were pre-COVID. In August, we saw the highest number of ER visits since the onset of the pandemic. All right, and I know just September continues to be busy with what you've been hearing a lot of the overhead announcements. All right, looking at our gross revenue recap, deliveries were below budget by 16 or 11.8%, but the average charge per case was higher, driving birthing center revenue up by 76,000 or 2.2%. Our cath lab cases were above budget by 6, with more cardiac cases resulting in cath lab revenue being up 616,000 or 4.7%. Our emergency room visits were above budget by 23.4%, driving emergency room revenue up by 1.8 million or 18.2%. Patient days were above budget by 639 or 14.4%, and this resulted in room and board revenue up by 5.6 million or 16.1%. Our total surgeries were higher than budget by 12.5%, with more neuro cases driving surgical services revenue up by 5.7 million or 15.7%. And inpatient and outpatient activity drove ancillary revenue above budget by 12.6 million or 15.1%. So overall, that was the breakdown of our gross revenue. Now looking at our payer mix, we did see, as you can see, government-sponsored patient revenue made up 74.1% of total gross revenue. This is higher than budgeted by 1.9% and also higher than the prior year by 2.6%. As you can see, the largest increase was in our Medicare-sponsored patients. HMO was 2.5% of gross revenue, which is below the budget of 2.7% and lower than the prior year percentage of 3.1% of gross revenue. PPO was 22.1% of gross revenue, which is below the budget of 23.1% and slightly lower than the prior year percentage. Private pay was lower this month at 1.3% of gross revenue, which is below budget of 2%, and if you remember what Chris mentioned, it was 2.5% of gross revenue in July. As you can see, we did have a higher than budgeted total government-sponsored payer mix, which did impact our net revenue. Preliminary net revenue for the month is estimated at 43.7 million compared to a budget of 41 million. And that's before any supplemental revenue, so an increase of the budget at about 2.7 million. So we did have a good month, but it still was impacted by our government-sponsored. Preliminary productivity indicators are productive FTEs. This is based on fixed FTEs budget. We're above budget by 59 or 4.6% at 1,339. Non-productive FTEs were above budget by 19.5 or 11.4% at 190.7. And total FTEs of 1,529.8 were above budget by 78.8 or 5.4%. If you look at our productive FTEs per adjusted occupied bed, so taking into account the high volume that we saw, it was at 5.09, which was lower than the budget of 5.96 by 14.6%. And our total FTEs per adjusted occupied bed of 5.81 was lower than the budget of 6.76 or 14.1%. I will say that our total FTEs per adjusted occupied bed at 5.81 is the lowest that we've seen since May of 2019, and at that point it was 5.86. So as you can see, we had a very busy month and saw that in our FTEs per AOB. And looking at our flex budget, we were below that at 25.4 FTEs. So moving on to our outpatient statistics, Whitmouth clinics were above budget in August by 453 or 2.7% at 16,969. And this was 18.2% above the August 2020 visits. Our DevCo visits of 2,281 were below budget by 21 or 0.9% for the month of August. If you can, in terms of that breakdown, you can see outpatient rehab center was down by 16 or 1.1%. Our radiation oncology center was lower by 56 visits or 15%. A lot of that is due to the departure of Dr. Lee. And if you, we do have two new physicians that have joined Dr. Eftemia. Also, Dr. Eftemia during that time did take some time off. So a lot of that was driving some of the decrease in radiation oncology treatments. Our Washington Outpatient Surgery Center was 51 cases above budget or 10%. And Ohlone was at 0, but we expect them the visits to resume in the fall when students return to campus. So we'll be seeing that. Looking at our financial statistics, our days cash on hand for August ended at 163 days. It's an increase of 5 days from last month. A great deal of it was an increase in patient collections that accounted for those 5 days. As you can see, our days cash on hand were higher in the prior year, and that's really, if you remember, due to the COVID relief funding that we received in fiscal year 20. And it did decline as we spent down those funds. Our days of gross revenue and accounts receivable were 69, primarily due to higher gross charges in the month. And although patient collections also increased, it was not enough to fully offset the 11% increase in accounts receivable. Then lastly, as you can see, there were 1,175,720 in charity care applications pending or approved in August. There was one high volume account of over 400,000. We did have a high volume of pending charity care accounts. I do want to say that all of those have already been accrued for in bad debt, so you won't be seeing that hitting going forward. So we are doing some catch up too with that. All right, so that is the end of August preliminary report. Are there any questions?
Kimberly, we had a higher length of stay in August. My question is, was this due to increased COVID, decreased short length of stay admitted joint patients, or were there other factors involved?
I do think it was multifaceted. I think that we did see a higher number of COVID patients, which has a higher length of stay. We also had a higher, just in general, case mix index. So our patients were sicker, and so that also drove the length of stay. So I think that, and the surgical volume with more on the outpatient side also impacts it. So I think it was a number of factors that impacted it. But I think a great deal is August was really when we were starting to see the increase in the number of COVID patients and that higher acuity.
Thank you. Any other questions for Kimberly? Okay, if not, we'll move on to our action item. That's resolution number 1229. And Kimberly, if you could provide the background for this.
Yes, we're presenting for recommendation for approval on is the terms of agreement between Washington and the Teamsters Union, Local 856. This covers around 125 of our employees, and it does cover our accounting clerks, our coders, our health information clerks, lab secretaries, registration clerks, patient account reps, storekeepers are some of the areas that are included under 856. What's being recommended is a 3-year term, September 1st, 2021 through August 31st, 2024, so a 3-year contract. In terms of across the board, there is a 2% across the board increase for all 3 years, so 2%, 2%, 2%. We also did find that there were some of the areas needed to have market adjustments. Those included the coders. So for each of those 3 years, they would also receive a 5% equity adjustment in each of those years. Also, the payroll associate and senior payroll associate employees would receive a market equity adjustment of 3% to their base pay each of those 3 years. And our communications operators would receive a 2% equity adjustment in each of those 3 years. We also had some increases in the differentials. The PM differential increased 15%, our night shift differential 25% increase, and our weekend shift differential a 25 cents, increase. So each of those 15 cents, 25 cents, and 25 cents increase. And again, all of this is based on market data that we do, and so we know in terms of the Bay Area and similar hospitals. The total cost of the contract amounts to $1,263,000 over the life of the contract. It is within the budget that we had established for this, and we were notified at the end of August that the union had voted and ratified the contract. So we are pleased to be presenting it to the Board of Directors this evening for approval.
Great. It's wonderful to see those negotiations come to a successful conclusion. So at this point, I'd entertain a motion.
Mr. President, in accordance with district law, policies, and procedures, I move that the board approve Resolution 1229, tentative agreements to be incorporated inside a memorandum of understanding with the Teamsters Union Local 856, a recognized majority representative under the terms of Board Resolution 331A.
Great, thank you. Do we have a second?
Second.
Second from Director Epen. Any questions or comments? If not, Dee, could we have a roll call vote?
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Okay, great. Motion passes. Resolution 1229 is approved. Kimberly, do we have announcements?
I do have a couple. I do want to announce our Employee of the Month for September. That is, I'm pleased to present Anna Mazet, our clinical dietitian. As Employee of the Month for September, Anna has known since high school that she wanted a career in the field of nutrition that would allow for her to help others. As a clinical dietitian and certified diabetes educator, Anna has shared her knowledge and passion with patients at Washington Hospital for over 35 years. She began her career at Washington as working as an inpatient dietitian. She saw many patients who were suffering from complications from diabetes. Anna recognized the need to help people understand how gaining control of this condition could lead to a higher quality of life. Anna became a certified diabetes educator, and when Washington Hospital launched the Outpatient Diabetes Education Program over 15 years ago, she was ready to, as she puts it, help patients build a bridge to better living. And I think all of us know that she has done that. And she's done it with a compassionate approach. Anna educates people on how they can make small changes that can have a big impact on their health. When she sees a need, Anna steps up and helps. She doesn't wait to be asked. Anna knows that through her knowledge, experience, and understanding, she makes an impact on the health of the patients she sees. Anna's approach to care has always been to put the needs of our patients first. 19 years ago, Anna and her husband, Greg, welcomed her daughter, Sonia, into the world. It was a good thing that Sonia was born at Washington Hospital because Anna worked up until the day of her delivery. Someone who loves her job, Anna feels fortunate to have grown in her career at Washington Hospital, and we are fortunate to have someone like Anna working with our outpatients. Congratulations to our September Employee of the Month, Anna Mazai. I also just want to give a few other updates in terms of the calendar. I know we talked about our COVID. To date, since February 1st through September 2nd, we have given 66,484 COVID vaccine doses. We've also given 328 additional doses to the immunocompromised patients, as we had talked about. The 2021 Central Park Summer Concert Series, sponsored by Washington Hospital, concluded on Thursday, August 19th, with an estimated attendance of 3,500 people. On Thursday, August 19th, as part of Women Empowering Women Support Series, Dr. Leaphart presented must-do health screenings for women. We had 18 members of our community attended. And then on Thursday, August 26th, Dr. Collins Pallett, family medicine specialist, presented impact of obesity, why you need to get up and keep a healthy weight. And 19 community members participated, and since then, over 545 additional people accessed the presentation. Coming up, we have on September 16th, we have Dr. Leaphart that will present Navigating Your Mature Years with Purpose and Grace. On September 21st at 6:30, we have our emergency medicine specialists, Dr. Srinivas and Dr. Natalie Tet, our intensivists. One of our intensivists will present the signs and symptoms of sepsis. On September 29th, Dr. Tran, our gynecologist, and Rebecca Bissett, a physical therapist, will present chronic pelvic pain in women. And then two other ones on September 30th, Christy Caracappa, Health Insurance Information Service Coordinator, will present Medicare Open Enrollment, What You Need to Know. As we know, open enrollment's coming up for Medicare. And then lastly, on October 14th, Washington Hospital will host its annual Think Pink Breast Health Awareness event virtually. And the speakers include Dr. Dagoni, Dr. Seema Sehgal, and Dr. Bogdan Eftemia. So looking forward to Think Pink. I also want to mention that our Charitable Foundation's Grateful Patient Program continues to grow. With the goal of this program is to expand awareness of the foundation, both internally and externally. And recently, we received a $150,000 gift from a grateful patient that was facilitated by a member of our medical staff. So I want to thank that. I also want to mention that due to the rise in the Delta variant cases, the foundation has made the difficult decision to cancel the 35th annual Top Hat Gala. But we are going to go virtual with a lot of this. Our Top Hats Fund beneficiary, Washington Hospital's new inpatient acute rehab center, remains our philanthropic priority for the foundation. And we'll be sharing a series of videos from the hospital staff and physicians and patients that really describes the need and impact of this very important unit. So we will be having a silent auction and a raffle, but still will be doing looking for assistance with our inpatient acute rehab center. So that, excuse me, concludes my announcements for this evening.
Thank you, Kimberly. Well, we look forward to the Top Hat presentations. And I wanted to say it's really great to see Anna Mazzei as our Employee of the Month. She's been a wonderful person in our dietary department.
Yeah, it ties well with the stroke recognition that we received also. Yeah.
Yeah, right. Very good. So are there any issues that the board members would like to bring forth before we proceed into closed session? Okay, if not, we're going to go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to closed session.